Hartford Healthcare's Tina Verona. Thank you for joining us for another Facebook Live chat session. I am joined by Dr. Azemi. He's an interventional cardiologist at Hartford Hospital. Thank you so much for joining us.
Thank you, Tina, for having me.
So first, I want to talk about, you were just on Channel 3 on Medical Rounds, WFSB. In case some of you missed that interview and you're just logging into Facebook now, we're going to just start with the basics. You know, we hear about heart attacks, we hear about sudden cardiac arrest. What is the difference between the two?
So they're completely two different processes. A heart attack has to do with a problem with blood flow. You can have a partial or complete blockage in the artery, and that blood flow is responsible for getting to the heart muscle. When you don't have any blood getting to the heart muscle, you deprive it and ultimately get stunned or create permanent damage. Sudden cardiac death or arrest has to do with lethal arrhythmias or electrical disturbances called ventricular fibrillation, which ultimately causes the heart muscle to beat chaotically and ultimately stop.
Now, a heart attack, you can survive a heart attack. Can you survive sudden cardiac death or arrest?
You certainly can if you have medical attention as soon as possible. So if you are found by an innocent bystander, the most important thing, if it's an out-of-hospital cardiac arrest, is that they initiate basic life support measures until EMS arrives and gets them on, for example, an AED. And if the AED identifies a shock of a rhythm, you can apply that shock and hopefully restore normal rhythm. And by that time, hopefully they can get you into the ambulance and into the emergency part so you can get any advanced therapies.
Are the symptoms of a heart attack and sudden cardiac arrest, are they the same or are they different?
They're different. So you do have some warning signs when patients present with heart attacks, whether it be chest pain, arm pain, neck pain, jaw pain. As opposed to sudden cardiac death, these arrhythmias usually happen without warning. And the next thing you know, you're on the ground.
Now, there's an entire team that make up the cardiac catheterization lab at Hartford Hospital. You lead that team, somebody comes in with a heart attack, that team mobilizes. Everything happens so quickly. When you get that patient up into the cath lab, what starts happening there? Take us in that process, because time is muscle.
That's absolutely true. At this point in time, we're really working pretty quickly. Everyone has a role on the team to make sure that they do what they're supposed to do. We ultimately get the patient prepped for the angiogram, whether we go through the leg or through the arm. We try to get a catheter that goes up there. We take some pictures, identify the blockage, and then start working on the blockage to open it up. The quicker we open it up, the better the chance that the patient survives and the heart muscle recovers. With sudden cardiac death, we do the same exact thing. We basically take pictures of the arteries. It may be related to the arteries or it may be related to a primary electrical problem. But at that point, we'll know whether or not there's a blockage that's playing a role in someone's cardiac arrest. If we don't see any blockages, what we normally do is go ahead and try to apply any advanced life-saving therapies, such as an ECMO device or other percutaneous devices that we can apply to help patients that don't really have good function at that particular time.
We're talking to Dr. Azemi. He's an interventional cardiologist here at Hartford Hospital. He's the one that if you have a heart attack, or your loved one has a heart attack, is taken to the cath lab, it would be him and his team that uses these different devices, uses different techniques to save that life. And of course, as we said, time is of the essence because time is muscle. How much time are we talking about here before there are signs of damage, or how quickly does this all happen?
We're usually given about 90 minutes. Once you start to get beyond 90 minutes, there's a higher chance that you start to have permanent damage. So the quicker we can open it up, and clearly within 90 minutes, there's a better chance that patients do well and ultimately survive the event.
So we are, again, talking to Dr. Azemi. He's an interventional cardiologist. If you at home have a loved one that had a heart attack, or perhaps you had a heart attack, we do encourage you and invite you to ask him a question about anything heart-related. You are hosting a class coming up next week, February 22nd, how to survive a heart attack and things that you need to know. Obviously, prevention is key here, and that's one of the things that you're going to stress strongly in next week's class. Talk to us about prevention. What can people do keep their blood pressure down, family history. Let's talk about prevention.
I think prevention is key here. I think if we can prevent patients from coming to the cath lab, that's a good thing, and prevent them from having heart attacks. Well, how do we do that? Patients have certain risks. For example, if you're a smoker, you got to stop smoking. If you have diabetes, you clearly want to control their blood sugar. If they have high blood pressure, you want to control their blood pressure. And if they have high cholesterol, you want to put them on good medical therapy along with lifestyle changes such as diet and exercise.
Now, we have a question from someone. How do symptoms for women differ? They are different from men.
Absolutely. Women tend to present with atypical symptoms. So they don't have to present with crushing, chest pain. They can have, a sharp pain. They can have one arm that's hurting them. They can have both arms that are hurting. They can have back pain. They can have sort of belly pain. Women clearly present differently. So if they have risk factors and they have some of these atypical symptoms, it is a good idea that they at least see a medical provider.
Now, what's interesting is, and we've talked about this before, there are not so obvious symptoms sometimes, like teeth pain or jaw pain. Is this indicative of sudden cardiac arrest or heart attack, or is this all the same? Can it be the same? And how do you know when to go and see a doctor?
So if someone has jaw pain or tooth pain, it's most likely, if they have the risk factors, it could be a problem of blood flow. Now, sudden cardiac death usually does not manifest in symptoms unless you're having a heart attack. So not everyone who has jaw pain or teeth pain should be seen for symptoms of heart attack. However, if you have risk factors, that's certainly something that should be on the top of the list. So if you have those risk factors, you have these symptoms, you clearly should be seen by a medical provider to make sure that someone's not having a big heart attack. The easiest way to do that, if you're seen by a medical provider, is get an EKG. Mm-hmm. Not all heart attacks are seen on EKG, but it's at least the first step in the evaluation.
And I think it's also important really to know your numbers. Know your blood pressure, know your cholesterol, your HDL, your LDL numbers, to really know your numbers. How much, or how, if you can, break it down in terms of how much does genetics play a role versus diet, exercise? How does all of that factor in?
So lifestyle modifications, including diet and exercise, are very important in controlling your risks. There are certain things that we can't modify. For example, your genetic profile. So those patients who have a family history, there is clearly patients who are at increased risk genetically of having heart disease. That's something we can't change. But the one thing they can change are modifiable risk factors such as smoking, diabetes, high blood pressure, and high cholesterol.
All play an important
Absolutely.
role. We're talking to Dr. Azemi. He's an interventional cardiologist here at Hartford Hospital. There's an important class coming up next week on February 22nd. Know the risks of heart attack. I encourage you to attend that class. It's with Dr. Azemi and his partner, Dr. Eric Olagino, who's also a cardiologist here at Hartford Hospital. Some really important information that you're going to be going through. I want to get back to some of the life-saving devices that we have here at Hartford Hospital. ECMO, extracorporeal membrane oxygenation. Did I get that right?
That's actually really good.
It is. Okay, good. All right. I practiced.
Said it better than I did.
So we do have that device, which is a lifesaver in many cases. When would you use this device? For sudden cardiac arrest? And explain what it is.
So the device is basically an external pump. We put patients one tube, and these are big tubes, where we place one in the vein and one in the artery, and we completely take over the job of the heart. Who do we apply this to? Well, first of all, we have excellent heart failure specialists that we team up with to make the decision on whether or not we're going to use this device. Patients who are very sick and we think that they're going to have a good outcome with this device will apply the device. There are other devices that we have that are not as strong, but ones we use more commonly in the cath lab, such as an intra-aortic balloon pump and a device called an Impeller, which are all devices to help relieve the heart muscle when it's under a tremendous amount of strain so that we can move blood forward to the rest of the body.
Right, and it gives you time to do what you need to do, where in another case you wouldn't be able to do that without these life-saving devices.
That is correct. People who are in sudden cardiac arrest from a heart attack, when they have these lethal arrhythmias that medicines won't get rid of or shocking the patient. Those are the patients that you know, if that happened in the cath lab, the thought of placing these patients on ECMO should cross your mind.
Yeah, absolutely. I want to also talk about, and a lot of folks, you might not realize this, but hypothermia treatment plays a role in someone having a heart attack, and you might not realize that, but it does. Tell us how that works.
So hypothermia, we know, is a life-saving therapy for patients who come in sudden cardiac death. If they've had a lethal arrhythmia secondary to ventricular tachycardia or ventricular fibrillation, we know this therapy and has been proven to be beneficial in terms of survival as well as brain function recovery. So patients that have a heart attack, we normally don't apply this therapy. But if they have a heart attack and that leads to a sudden cardiac death, it's certainly something that we would think about putting patients on to benefit their survival and hopefully their brain function.
And you'll be talking about this during next week's class, which we strongly urge you to attend. If you have further questions or if there's anything that you want to know about heart attacks, we're talking to Dr. Azemi, an interventional cardiologist at Hartford Hospital. When someone does come into the cath lab, it could just be for a heart attack and you're stenting them, right? It doesn't have to be for sudden cardiac arrest. All heart attack patients come through the cath lab?
That is absolutely true. All heart attacks do not lead to sudden cardiac death. It's usually the big heart attacks that have a propensity to lead to sudden cardiac death. When patients come in with heart attacks, the main goal is to open up the artery as quickly as possible. We try to identify the artery that caused the heart attack and go after that. Once we restore normal blood flow, if everything looks good, we go ahead and just bring them to the ICU. Some patients, their blood pressure just doesn't respond appropriately, and that's when we need to think about other devices that potentially will hopefully save their lives, such as an intra-aortic balloon pump, an Impeller, and possibly ECMO.
And now ECMO it can sometimes be used on the road to patients as well.
Absolutely. Our team of heart failure specialists, along with the CT surgeons, they have done this on occasion where they actually identify a patient from an outside hospital. They go out and place these patients on ECMO and bring them to Hartford Hospital for further evaluation and management. Some of these patients may wind up coming to the cath lab at some point to see whether or not they have any blockages that may be playing a role in their sudden cardiac death.
And how quickly does that have to happen, that transport and getting them on ECMO?
Well, it all depends on what the reason they're going on ECMO for. If they're actively going CPR and we think that they have a good chance of being placed on ECMO and surviving the event, it has to happen pretty quickly. But if they have a blood pressure, they have a rhythm, but it's not as good, and they think that the patient is having a heart attack, it is very important that they get on a therapy like ECMO and then bring them to an area where they can take a look at the arteries and potentially fix these arteries.
Back to the prevention, because again, that's key to avoiding all of this that we're talking about, but prevention is so vital. If someone has a family history, what kinds of questions should they be asking their doctor? Should they be asking for a stress test? What should they be doing?
So if you have a family history of heart disease, the one thing you need to ask the patient is to see whether or not they have any risk factors, i.e. diabetes, make sure they don't have diabetes, check their blood pressure to make sure they don't have high blood pressure, and ultimately their cholesterol. Patients with family histories tend to have a higher propensity of having increased levels of cholesterol. And if they do, there's therapies such as statins that they can be placed on to hopefully reduce their levels of cholesterol and prevent progression of plaque inside their arteries. So it's very important that they get a full workup to make sure they have no risks, and if they do, we need to take care of them. Some patients don't have any of these things, but genetically they're at increased risk of depositing cholesterol places where they shouldn't go. So there are things that you can do for patients who have family history but don't need to have, for example, a stress test. They can do a coronary calcium score, which is a CAT scan of the arteries to see whether or not they have any calcium in their arteries. And if you do have the presence of calcium, that would push the physician to at least put them on a drug called a statin. So that is a good way for patients if they do have a family history, they're not having any symptoms of any heart disease. That's certainly a very good testing modality to see whether or not these patients should be placed on drugs like statins.
Yeah, and knowing your numbers too is important in terms of cholesterol, your total number. What should the numbers be? What are good numbers for folks out there to keep in mind?
So roughly, the cholesterol level should be, total cholesterol should be less than 200. The HDL for men should be above 40, and for women above 50. The bad cholesterol, again, depending on your other risks, can be anything less than 180 or less than 70. So it all really depends on these risks. And we usually take these risks, we plug it into a calculator to give us your risk over the next 10 years of an event happening. And depending on that number, we will then put you on a therapy and give you a goal in terms of where your good and bad cholesterol is. Nowadays, they really don't stress too much about where your levels of bad cholesterol should be. I'm not an expert in cholesterol, but I think we all do believe that if we can get the levels of LDL, which is the bad cholesterol, as low as possible, you have a less chance of having heart disease and potentially heart attacks. Drugs like statins not only reduce or prevent the progression of cholesterol inside the arteries, but it also has these anti-inflammatory properties that is key and vital for preventing heart attacks from happening, stroke, and ultimately dying.
Yeah, and so that's why, again, it's so important to know your numbers so that you know
Absolutely.
if your HDL is high or low or your cholesterol is, you know kind of what you're dealing with or what to expect, and you can begin to prevent that.
Absolutely.
Let's talk about the recovery process, because this is also important too after you've had a heart attack, to go through cardiac rehabilitation. That's a very important step that a lot of people sometimes skip, but it's very important.
That's a very good point you bring up. I think every patient who comes in with a heart attack or has heart disease and they've had a stent placed or a weak heart, they should ultimately go and get enrolled into a cardiac rehab program. We know, based on the research, that if you go for cardiac rehab in patients who've had heart attacks, in patients who have heart disease or weak hearts, these patients do better than those who don't. So I think it's a very vital step in terms of their recovery. And you can easily get these patients enrolled into programs. Insurance companies cover this for at least 36 weeks, if not more. And it's a good way for patients who've just experienced, a life-changing, event to actually get back into exercise under a controlled setting. There's usually a nurse, a physician, an exercise physiologist where you get put on a monitor, you get on a treadmill, and you can start to exercise. And it actually motivates people when you're done with cardiac rehab to actually start exercising on your own.
We're talking, of course, to Dr. Azemi. He's an interventional cardiologist here at Hartford Hospital. Really some eye-opening information, I think, that you're giving. And of course, we're talking about the recovery process when somebody does have a heart attack. And there is also that concern of deficits after or permanent damage after, whether it's to the brain or to the heart. But these life-saving devices can help with that, can really help with that in terms of that long-standing deficits after an event.
Sure. So in the midst of a heart attack, once we restore normal blood flow, that's important. But if we find that they had a really big heart attack and their heart muscle is weak, these devices that we deploy during the procedure will hopefully relieve some of that stress in the next day, 2-3 days, so that it'll allow the heart muscle to start working, but won't work as hard. And that ultimately can translate into better outcomes.
Mm-hmm. So what's the one thing that you want to say to folks out there watching us right now as an interventional cardiologist is it prevention, or what's the one thing that you want to tell people about heart attacks?
I think the important thing is really prevention. Mm-hmm. Once you get to the cath lab, something bad is going on. And if you have risks that you can modify, that is the best thing to do in terms of getting it treated, getting it under control, and doing things that you can potentially change. Obviously, if you have a genetic problem where you have a family history of heart disease, you can't do anything about that, but you can certainly change the way you live. If you're smoking, you gotta stop smoking. And if you have all these other risk factors, they just need to be controlled. Do the right thing with diet, lifestyle modifications. I think prevention, if I were to stress one thing, is the most important thing.
And we hear smokers, having heart attacks. How does smoking come into play? How does that contribute
Sure.
to a heart attack? Because we always hear, don't smoke, but why
Right.
shouldn't you smoke?
So smoking, what it does is it does several things. The first thing it does is it accelerates the process of plaque being deposited inside the arteries. It increases the bad cholesterol, lowers the good cholesterol, but it also causes the heart muscles to constrict, meaning narrowed. That is all stress on the heart and on the heart arteries. So it's got several things that it can cause in terms of heart disease. So I think it's very important that you stop smoking. Most people will give you a story where someone smoked forever, but that doesn't mean that you do not have any blockage, at least that's there. It hasn't manifested itself, but it's clearly a problem, and it's something that can easily be addressed.
Now, I found this interesting when I was talking to Dr. Olagino, who was describing how some people have heart attacks, and he was describing it like a scab on your heart, and the slightest exertion that you could be doing could open that scab, and let's just say you have a 20% blockage in your heart. By that scab ripping off, it could completely block it 100%.
That's correct.
I find that fascinating. Talk to me about
Sure.
how that happens.
So most heart attacks, the big heart attacks, usually happen in patients who have at least a 50% blockage or less. So if you have a 20 to 30% or 40, 50% blockage, that blockage has a lot of cholesterol. And in that plaque, this high amount of cholesterol causes a lot of inflammation. There's a thin layer over this wall, and so that thin cap can actually rupture, and it's like a volcano that erupts, and underneath that, it actually is very sticky, and it actually recruits blood, and it goes from a 50 to immediately to 100% blockage. So a lot of patients will say, well, will my heart attack prevent, or will my stress test prevent heart attacks? And the answer is no. When you go for a stress test, you're having symptoms. Those symptoms will usually come from a blockage that's 70% or more, and that's what the stress test is trying to detect. However, I just got done saying is that a majority of heart attacks come from a blockage that's 50% or less, and that's because of that process that I just described. So Dr. Olagino is right. It is like a little scab. Any stress, whether it be high blood pressure, high sugars, smoking, or strenuous activity like shoveling snow, that can certainly peel back that scab, and underneath that scab is very sticky stuff, and it brings all this blood, it recruits, and it clots off immediately.
Wow.
And there's the big heart attack.
Yeah, that to me is so fascinating. And can that lead to sudden cardiac arrest?
Absolutely. So that will first lead to a heart attack, and when that heart attack, that heart muscle is being deprived of blood, it becomes very irritated, and in that area where those electrical circuits are going through, it can actually cause further irritation and lead to these lethal arrhythmias like ventricular tachycardia and fibrillation, which ultimately lead to sudden cardiac death.
Now, you've said before, heart attacks can lead to sudden cardiac death. Can you just have sudden cardiac death
and not have problems with your arteries?
Right.
Absolutely. So if that happens, again, that's usually because they have a primary electrical problem. There are several electrical problems that our electrophysiologists deal with on a day-to-day basis. But these patients can certainly have normal arteries. When we bring these patients to the cath lab, because it is recommended if you have a sudden cardiac death and there is an electrical rhythm that we think is related to blood flow issues, they should certainly come to the cath lab. We take pictures of the arteries to find out whether or not they have any areas of the heart muscle that are being deprived of blood from blockages.
And those are patients with arrhythmias or erratic heart rhythms or heart beats that you would use a pacemaker or some type of device that would help shock you back to prevent sudden cardiac arrest.
Absolutely. So the ones that we're really worried about are from the arrhythmias from the bottom chambers of the heart, and those are ventricular tachycardia, ventricular fibrillation. When we identify someone who's survived a cardiac arrest, those patients would clearly benefit from placing a device like an cardioverter defibrillator. So it's very important that we get our electrophysiology colleagues involved once we identify it's not a problem with blood flow and it's primarily electrical problem.
So it really is an interdisciplinary approach.
Absolutely.
Depending on whether it's electrical or whether it's clogged arteries. There are devices, and again, it is preventable.
It is. A lot of the sudden cardiac death, there are some genetic inheritance patterns that will lead to certain patients having these primary arrhythmic events. Sometimes it manifests itself as sudden cardiac death. So if you know someone in the family that's had sudden cardiac death from an arrhythmia, such as ventricular tachycardia or fibrillation, those patients should clearly be followed up and seen by a physician to see whether or not it's something that's inherited. Those patients would clearly benefit from an ICD or an implantable cardioverter defibrillator.
Yeah, some really great information. I really appreciate it. I certainly things that I didn't know, and you hear so much about heart attacks, but a lot of times you really just don't really get into the weeds of it and really understand how this happens. And I think this is so beneficial to everybody. We definitely invite you to attend the class. It's coming up next Wednesday, February 22nd at 6:30. It's in Wethersfield. If you call to register at 1-855-HHC-HERE to register for that class, I highly encourage you to do that. Dr. Azemi and his partner, Dr. Eric Olagina, will be hosting that class. You can ask questions. They'll go into even greater detail than we have gone here on this Facebook Live chat. We thank you once again for joining us, and we'll see you soon.